Yeah, Nick Vote, thank you very much. I think qualify about friendship, what it is in the slogan of this meeting. We may disagree about a few things academically, but I think we're very close to be the best friend in us. And Nick is, as you may know, is Swiss, he's from this country, so a small country can be highlighted in other places since he's one of the giants of HPB surgery, and I think everybody in Switzerland is very proud and recognize those Swiss who are outside. So what I will try to do today is, I was not sure, so to take a little bit the freedom to talk about what we learn in academic surgery, not only from success, but sometimes for failure. First, I want to dedicate this lecture to Gilles Manta, who was the co-organizer, the co-president of this meeting. Unfortunately, he passed away a few years ago. It starts by some questions. Here, Dad, is the world round or flat? And the dad answer, what could that possibly have to do with us? And I think it comes with the first things. The first lesson that we have is curiosity. If we're not curious, then we go nowhere. So in order to go somewhere, we need to observe and then to ask the right questions. And here, Nobel Prize, I think, has very well highlighted where we start in science is to ask a simple question. What we tell to our student, a stupid question, and that makes things go forward. I go back now to a different period of my life and that to see what I learned. I started when I left Switzerland. I went to the laboratory of Steve Strasberg in Toronto, and at that time, there was an observation in preservation injury. We started to be very interested that what's happening is that the endothelial cell detach from the sinusoid here, and that was what was known at that time when I entered the lab of Steve Strasberg. So a simple question, pretty obvious, was what happened after reperfusion injury here. And then we developed a model that was the work in the lab, the isolate perfused rat liver model. And this is my first paper. I don't know if Steve is here. In the lab, very simple observation. And what we saw here, this is the leukocyte that you have here. This is the time of reperfusion. And we could see that the longer the cold preservation was, more leukocytes were attaching to the sinusoid in the liver. Very simple observation, which trigger, in fact, further questions. I will move a bit in the clinical to, at the end, have some lesson. So, at the same time, in the 90s, came the laparoscopic cholecystectomy here. It was new, appealing, people wanted to have it, but it was unknown morbidity in these cases. So the simple question is it safe to do that? And then at that time, while in the lab, again with Steve Strasberg, we were thinking about morbidity, how we can assess morbidity, and we developed a simple classification that we use, in fact, to use the data from Geneva and the data from Toronto to show some advantages of the laparoscopic cholecystectomy. So here also, when we do some research, whether it's clinical or the other one, we see, that's the secret of that we see what everybody is saying, but we think what nobody has thought before. And that, if we do that, then it may go a little bit further. So the need is to think a bit out of the box and not just follow what everybody is doing, but sometimes challenge different things. I go back to the lab here at some point. We knew a platelet was important in different areas, that it stick to the liver in liver transplant, that is in aggravate reperfusion injury, and it may cause some apoptosis or necrosis of the endothelial cell. So here came a simple question. We're interested in regeneration at the time of small foci issue. Then we wanted to test a platelet in this. And then a fellow came in the lab from France, Michael Zurtel, and we need the good questions, that's important, and we gave him a very simple question, what platelet does in liver regeneration? So Michael learned the standard technique of hepatectomy, so he could reproduce here as a marker of regeneration, 70% standard model, so the liver regenerate, nothing new. But there was a problem, because Michael worked on this, and to do a hepatectomy in an animal that has no platelet is not easy, it bleeds, And I can remember, I don't know if Michael is here, but after 1 year, Michael, I don't, basically enough, and he said it will never work. I mean, we have a serious problem here because we cannot even start. And here it comes what Thomas Ellison say. I think this is a very important secret in academia, is that we need to try 1 time more, and maybe we find it. And that's what Michael did. And after that, he could do it, and then first observation, if you take out the platelet, then the liver does not regenerate. And then I just show here, it's not a talk about regeneration, and then by different model, he could show that there is 1 amino acid, L-tryptophan, that converts to serotonin in the platelet, so that's the standard physiology. Then we were lucky to block the enzyme that take the tryptophan to serotonin, and by blocking that, then bingo, we had no regeneration, suggesting here that this is serotonin that is involved, but we need to do a little bit more here, and we give a substrate further down in the pathway, and here also we're lucky to see that we restore regeneration. So I think it's a good example of convincing data, and that enable Michael to get a paper in Science by demonstrating serotonin in liver regeneration. And then, of course, it opened the door for many other work, and many work we've done here in our laboratory about serotonin in different conditions, in NASH, in the older liver, in cancer, and in repair after ischemia. So nice study done by other people, but also importantly, 120 papers from outside of the lab were published showing the effect on the importance of serotonin. So one lesson here maybe is that the test of time and the impact on others give the real value to what we are doing, and that takes usually many years, and sometimes it doesn't pass. Doesn't mean things were wrong, but the importance comes from this. I go back now to the work on outcome research and complications. So work this in the lab, and 10 years later was not used. I mean, 70 citations, and is that a wrong idea? We use it. Basically, most papers were from our group. Not much happened here, and then we applied the same principle. So early in Zurich, Daniel Dindo was a young resident. We say, well, I think it's still a good idea. Let's look at that again, and we modify a little bit these things, not too much, but a little bit. We review, we ask other people, and then we came with this paper, this classification, right, which is the same basis that was initially when we take the treatment for complication to grade the severity of that, with a pretty simple idea, in fact. And now we got more than 15,000 citations with this work, which is not very different than the initial one. So I think a very important thing that when we fight is that nothing is stronger than an idea for which the time has come. And the early 2000s, with many things, there was really more need to have such a classification. And then you go further, then it's fine, but people don't have one complication, they have several complications, and then we don't know how to rank one or the other one. And this was something that I was thinking from a long time here. Can we create a simple scale metric that will tell morbidity as we can quantify mortality? And I was part of this very nice group, the Balliol group here in Oxford, which involved in evidence-based medicine, the ideal. And I remember I talked to a very smart statistician, and basically what I was told would be very difficult, it's basically impossible to find such a thing. Well, we still persist with the help of others, and Xenia was here, work also with a group in Amsterdam, a statistician, and then we try to look at how could we quantify that in a convincing and useful manner. We based on our classification that we had, that's relatively easy. We wanted the perspective, severity, who decides, so we decide is the patient and the physician, I think it was important. And then with the help of Milo Puhan, our epidemiologist, we have to go to the world of economy. They are much more sophisticated than in medicine with formula, because they need to evaluate in the different, the feeling about different economic values around the world. And then we told we want also something simple, although it will not pass, 0, no complication, 100 deaths. And then with a formula that I will not detail here, and we validate that, then we have the comprehensive complication index, a value that gives us a simple idea about morbidity. And now with these two patients, we can rank them, and then we know which one has the more severe morbidity. Then we also learn when you develop other advantages. For example, the CCI enabled to monitor complication over time. So we can know 3 months, 6 months. So we have really a very nice, easy view of what complications are, as an example here, how it developed. It's been used here in Korea by a very famous gastric surgeon. He used this to rank even his surgeon. Is that a good idea? I mean, you don't control how it is used, but he used, and the surgeon have to go and meet him every 2 months with their own CCI, and they have to justify if they are not according to the standard. Another question that I think it's important for us here is, does research matter for the clinical mission? We heard, and if we just listen to administration, they would rather not to have some research. It costs money, put you a way of treating patients. So for what exactly? So this is really a fight that we have. I just show you here an example of what can help and why it's important. Here, if you do research, it's space, personnel, costs money, okay? Then I take the example of Michael Zürtel, very happy, you get a paper in Science, wonderful, this is very good. Still, the hospitals see absolutely zero benefit, they don't have a drug, they cannot get anything. It costs even more money because 4 or 5 fellows are coming and they want to work in the same lab, so that's not an advantage. Now, if you focus, that has to do on your field. So we develop also at the same time an HPB center for patients with real HPB center with dedicated nurses, etc., and you do some research on the side. Then what may happen, maybe a bit lucky, then suddenly the New England come and say, can you write a medical progress about liver surgery and regeneration? And that has an impact because people read it, you get some credibility, it takes time, then number of patients will come, they will call, and at the end it may even be very highly cost effective to do this. So I think this is by Mr. Blandon from Harvard. I think this is very important that we fight that sustained success of academic health center depends exclusively on outstanding research. I think this is very important to go and to follow with that. So another study that we did in the same direction, I take some randomly example here, simple, this Huggins Nobel Prize questions. Can we compare objectively the result of surgery among centers? Something that's important for us. And we see bias, etc. Do we have really something that will convince us, meaning we can go in a good direction? And that here came as an example here. You have a case here, center 1, no problems, center 2, a little bit more problems, and center 3 has really serious mortality and morbidity in this. How can we compare this center? All these arguments. Center 3 is the referral center, my center. We do a lot of incredible cases, so of course, we cannot have the result of those who do wedge resection. But is that convincing enough just to state that? So we came with this idea of benchmarking seen by us, by the surgeon, to try to do it where we have not too many statistical bias and multivariate analysis and things that we know are far from being perfect here, and how can we measure this gap? So I just show you one example here. This is a very active area of work now here. So we did here, was published recently in the Annals of Surgery by one of our fellows from Luxembourg, was in Belgium before, Clavien. And we decided here to identify in the world the best result you can have with a procedure. So you take 3 continents, many centers, large center, you define criteria here, and at the end you identify benchmarks. So the first observation, so the good cases were based on the MELD. I would not go in many detail here. So the low risk cases in liver transplant was about 25% for the total of transplant done among these countries. Just as an example here, we'll show you before, we can monitor a complication over time. So one question that we have every time, how long we need to follow the patients? 1 week, the time of discharge, 3 months, and there's absolutely no consistency. Here we have data, and you can see that the CCI, at least the morbidity, is increasing very significantly over the first year. So here we have an observation that if really you want to evaluate liver transplant seriously, you should provide data for at least 1 year for every patient after the transplant. I will not go in detail here. In this group, we could have benchmark value, meaning if you're below that, you're fine. You are as good as the best cases. 6 hours if lung surgery is important, 3 units of blood, 4 days in the ICU, etc., based on 17 centers around the world. So here's objective data, real data that we have, and we can compare, and basically if you are within this data, nobody can criticize you, and if you are above, then you have to see the risk and evaluate, and you have just to justify a little bit what was done. And we have used that. Now again, we open another door here to go further here. So we were saying, well, this complication is based on treatment for complication, the grading system, the CCI is a formula, is probably a correlation with cost. And that's what here Roxanne, who's doing a PhD now in our clinic, was looking whether or not we could use that for cost. Because now, many of us have no MBA, I don't have an MBA, we are manipulated by the administration, by many people, and the only thing we heard, we cost too much, etc., etc. And that really destroys very often our mission. So we thought maybe we need a small tool to tell the administration what we are doing, and she presented this work at the European Surgical Association, will be up here in the November issue. First of all, there was a very good correlation between the CCI and the cost, and then with some statistic, she take the type of surgery, the cost, and then based on the CCI, you can increase the cost and the age. And if you adjust that in the formula, you're probably as good, if not better, than any administrator in your hospital to calculate. So we have a tool that belongs to us, when if you use it, we could really argue with the hospital in this direction. The next things that I thought I will try is how can we become an academic surgeon, if that still exists. And we are a little bit like this painting from René Magritte. When we do this, well, when we in research, well, we are clinicians, so not too serious. And we're in the clinic, well, you're a lab guy, so you're not too serious. So it's pretty difficult to walk or to swim in this scenario. So here, I think what's also important here to consider is that the extraordinary achievement is usually based on opportunity, rather than just talent. And I will speak a little bit about that, and I come back a little bit to my career, that I was looking back and see what happened. Number one, very important, you need someone who wants to help you. And for me, it was Martin Allgöwer, who was a famous general surgeon from Switzerland, who died a few years ago at the age of 93. Here, this is just the letter that I received when I was a fifth-year medical student. He offered me a job. I have not much to show. At that time, there was 150 applicants for 4 positions. You need to be lucky. And not only that, he make you look good, offer you the job for 6 years, which was pretty uncommon. And he said, if you have any problem in between, talk to me. And he followed me in my career many times. Here, this is the first study that I did looking at CT in acute pancreatitis in the mid-80s. I wrote a paper that not have many matter. I went to Martin Allgöwer, I showed the paper, and basically he explained to me now that was very bad, but the material was interesting. It was pretty novel. He helped me, even apologized to be so critical, and that was my first paper published in the American Journal of Transplant, demonstrating or showing in the 80s that CT is very good in acute pancreatitis and can be helpful. Here's another one. You're in Switzerland, very small, you want to go abroad. Well, you can write 200 letters. You're lucky if you have 10 answers to that, if you just by yourself. What do you show? One paper, etc. You don't speak English very well, etc. You need someone. And Martin Allgöwer here organized, I spent a month and a half to go in the US, visit different places, and to see what could fit. And I end up here in Toronto. I was recruited by Bernie Langer in 1989 to go here. And here I had 2 further mentors, which I'm very indebted, which was Steve Strasberg, who is here, and Bernie Langer, and then it started. Then that was the start of something. So you need to be a little bit lucky, but not always so smooth. I'm in Toronto. I was paid the first year by the University of Geneva, did a PhD. Yeah, you can operate, things that you never operate. And then my boss here, which was very supportive, told me, it was in mid-93, well, it's difficult to come back because I have 4 guys who are older than you, much older than you. I cannot promote you. You come back as a resident. Okay, so, you know, you're in Toronto, and my first girl, you here, what do you do? Okay, Toronto, you can stay a bit longer. And then failure may lead to some opportunity. It can open the door to something else. And to make it short, then I had the opportunity to move to Duke University, to be recruited, also very lucky by David Sabiston at that time, later by Bob Anderson, They asked me to lead the liver transplant program, and we did the first pediatrics, some lab, etc. That's a huge opportunity. So a failure, it's very often extremely good things to motivate you and to go further in the, oops. So I think this is, I liked from Warren Buffett, if you sit in the shade, it is because somebody else has planted a tree a long time ago. This is pretty obvious, this. And if you, what is common in these pictures that we can see of overage, and I don't think has changed much today, what we see here is that there is a leader or there is a mentor here who helped the other one or who really show a little bit the way where to go. Mentor was the advisor of Telemachus, was the son of Odysseus and Penelope, and that was basically all the story of going of being a child, no experience, to be a reasonable adult. And here I just want to quote, because the talk, a little bit what I thought was very helpful here. For Bernie Langer was saying an expert is a man who has made all the mistakes which can be made in a very narrow field. That's very modest if you know Bernie Langer, who is certainly one of the most impressive surgeons I have ever seen in my life. And I would just say thank you, Bernie, because by just telling us, you save many mistakes from your students, probably not all, but many. Here, this is also a very well-known American right activist who wrote, in fact, the speech for Bill Clinton. I have learned that people will forget what you say, people will forget what you did, but people will never forget how you make them feel. I think this is very true, and here I want to quote our chief of orthopedics, a very good friend that just retired from the world specialist for the shoulder. I do not believe in transfer of knowledge, but I do believe in transfer of enthusiasm. And I think this is also important. Emotion and emotional IQ is central for the transmission of knowledge. I think this is something that is, for me, very true. Now, I will go close to some of the last. A big question today is, can we get it all with well-controlled working time? Worldwide disease, 40 hours in Europe, I think still 80 in the US. Can we do it in that way? Well, we need to look a bit at what we know. Number one, there is zero evidence of naturals with effortless float to the top. So people who are good from the beginning, does not exist, no strong evidence. People that reach the top, they don't work just harder, or even much harder, they work much, much more harder. And then we have the data from us. In 93, a general surgeon will work 30 hours before being qualified. In 2009, it's probably even less today, is 6,000 hours. That's the data what we have. We have this famous 10 hours rule to become very good. And there's no correlation between the intellect and achievement. This is work that make the difference. Let go in music, and if data in music is well known, here you have the musician, the good, and the big stars, and you can see the difference is not the talent at the beginning, it's how many hours they are working. Even if you take Mozart, he was 21 when he wrote his first masterpiece. That was 10 years after he began to really play piano. Nobody basically escaped to hard working and enthusiasm in this. So success really relies on countless hours of effort, and we may even last, like Federer here, a long time if you adjust many other things with that. What other things matter in academic surgery, and I think this is a good example, this association with all this focus, is the people you meet. That, I think, make a big difference. And first, I'm very indebted to these pictures here. I'm sure I forget a few one. Everyone here has played a major role to prevent mistake, to help you, to recommend you, and basically to have trust in, and I think we cannot have enough recognition for the people who have helped us, because we know perfectly without these people we would be just nowhere. And for each of them we learn a lot of things. And I think no matter what your accomplishment you make, somebody help you. I think this is probably universal things. And even some here, I found that this morning. Here you have Paul Gregg on the right side, and that's a picture taken recently, and even Paul was a mentee of Bernie Langer, and even when they become the age, they look the same. So I don't know if it's random, but some push even the admiration for the mentor just to look the same. So, of course, very importantly, we have to go from being a mentee to being a to being a mentor. So now I have the chance to have few people, and several are here. And of course, this is for us the biggest satisfaction. The people we could help, they contribute to research. Many of those are far away from Switzerland. And last night at the circus, we did pictures and was very touched to see that there is recognition on both sides between the mentees and the mentors from many different countries, from the US, from here. This is certainly a very, very big satisfaction. But probably above all, what counts is our patience. And we have to learn, we fail sometimes, we lose patience, but I think if we do our best, we dedicate, even when we lose, people could have some recognition, and sometimes we have incredible results that justify what we are doing. I thank you very much for your attention. Thank you.